have our own Dr. Satish Raj present to us today. So he is the section chief of the Adult Cardiac Arrhythmia Group. As well, he's the founder of the Calgary Autonomic Investigation and Management Clinic. He's really internationally recognized for his research and his expertise in the area of autonomic physiology and autonomic disorders. So we're really lucky to have him and have him come and present to both of our departments to give us an update on dysautonomias, an approach and management. So good morning, Raj. I'll hand it over to you.
Wonderful. Thank you for the kind words, and I'm very pleased to be here today. Hopefully you see the title slide. And I was asked to talk about dysautonomias, and I've taken the liberty of morphing the topic a little bit just because I'm not entirely sure what the breadth of dysautonomias are. It's sort of a grab bag that's used for a lot of things. And so I've reframed it to postural orthostatic tachycardia syndrome, or POTS, approach and management, and hope that's okay. If people had their heart set on other specific forms of autonomic dysfunction, I'm happy to answer those in the question session at the end. My disclosures are listed here. Not sure any have to do with the talk specifically. There is some on POTS, which is actually a new thing in the last couple of years. One of the things that's happened in the last couple of years, for the first 20 years of my career, there was no industry interest at all in POTS. But there are companies in early drug development now, so hopefully that may eventually morph into potential new treatments for POTS. And then research grant funding peer-reviewed from CIHR, at least until recently, Heart and Stroke, and some foundations. I do want to acknowledge the fact that we're on the traditional territories of the peoples of Treaty 7. We work and play here. This includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. And Calgary, the city of Calgary, of course, is home to the Métis Nation of Alberta, districts 5 and 6. So to my knowledge, I haven't infringed on any copyrights without fair use. Everything should be credited, and I do aim to use inclusive language. If I've missed, please email me, and I'll try to correct for the future. So I guess the first question is what is POTS? And the current definition has been adjusted minimally over the years, but it really goes back 30 years. It was in 1993 that Philip Lowe, who is probably the preeminent autonomic neurologist in the world, but at Mayo Clinic, put together a paper along with Ron Schondorf, who's actually a neurologist in Montreal. He's a Canadian who was doing his fellowship down there, that described the syndrome of patients with idiopathic orthostatic tachycardia. And the gist of it was, there was physiology and there were symptom criteria. The physiology was that the heart rate went up too much. And they defined that as an increase of over 30 beats per minute. This was in an adult population. It was based on statistics. It was based on, what they found in their normal population and said, this is 2 standard deviations above it, so this is excessive. Now, this in and of itself has challenges. One of them is that orthostatic tachycardia is physiologic, and the orthostatic tachycardia actually is high in the young and decreases with age. So coming up with a set cut point isn't dynamic in the way the tachycardia really is, but there's always a trade-off of simplicity. But what they found is that in adolescents and kids, and you'll see that this does affect a lot of teenagers, there are a lot of people that met the criteria who were perfectly well, and so they looked and redefined the criteria several years later, requiring a threshold of at least 40 beats per minute in patients between the ages of 12 and 19. Interestingly, there are actually no North American or European criteria for those under the age of 12. And this tachycardia has to occur in the absence of orthostatic hypotension. And the reason is not that if there's orthostatic hypotension, there's nothing, but orthostatic hypotension has actually been recognized for a long time. And if it's just a reflex tachycardia to that, the target is to treat the orthostatic hypotension, and the hope is the tachycardia would also resolve. Now that in and of itself is POT, right? That in and of itself is physiology. The key to POTS is the S. This is a clinical syndrome where patients generally feel miserable. And the hallmark symptomatic feature is that there's a cluster of symptoms, and the specific symptoms can vary, that are worse when the patients are upright and better when the patients lie down. So that's not to say every symptom has to go away completely, but if there aren't dominant symptoms that are worse with upright posture, it's hard to argue that this is an orthostatic disorder. And this has to be chronic. We initially, I think 6 months was required. I think a lot of criteria have decreased to 3 months. The truth is, there's probably not that much resolution between 3 and 6 months, so it probably doesn't make that much difference. But what they're trying to avoid is diagnosing people who acutely have a viral infection, for example, who may exhibit all of these as part of the acute adaptation to a virus, diagnosing them with POTS. Most people with an acute infection do get better within a few days. The difference is these patients, some of whom started with a virus, don't. They don't resolve, and so this lasts and lingers for some time. And then there are caveats. This has to be in the absence of other obvious causes of orthostatic tachycardia, whether that be drugs, whether that be severe dehydration for whatever reason, whether that be prolonged bed rest. So a few years back, we put together a group to come up with a Canadian Cardiovascular Society position statement on POTS. And as we were doing this, what we realized is that there was a problem both with recognition, where people were being underdiagnosed with POTS, but also with overdiagnosis. And one of the concerns was that there are people that are quite unwell symptomatically, where something's going on, but who don't necessarily meet the criteria for excessive orthostatic tachycardia. But they are symptomatic. And so you had two choices. You could say you don't have POTS. And while true, based on the criteria, what the patient often hears is, doctor said there's nothing wrong with me, and left upset. Or in some cases, doctors would diagnose them with POTS in the absence of tachycardia, which again is problematic in terms of both some of the treatment approaches, as well as if you're tracking patients and trying to figure out prognosis. It's difficult if the patients didn't meet the criteria in the first place. So we came up with sort of an ecosystem of orthostatic intolerance and came up with different nomenclature. So one was this concept of postural symptoms without tachycardia, or PSWT. And I grant you, it doesn't roll off the tongue seamlessly. And so maybe there's a better name for it, but basically something to recognize that there are patients that are symptomatic with stuff going on, in some cases, same stuff, some cases, different stuff, that don't meet the orthostatic tachycardia criteria. And we came up with this diagnosis of postural tachycardia of other causes, because as I said, if you have another cause, that's exclusion where you don't have POTS. But again, something's going on. The other thing that we realized is that there are different groups of patients. There are some patients that have primarily what I'll call a cardiovascular or a hemodynamic problem, right? Their problem are related to symptoms that we probably could relate to the tachycardia and drivers of that. But there's also a significant group of patients that have other issues, other comorbid issues. And in some cases, those other issues are actually the worst thing in terms of driving their poor quality of life. And the challenge then is that if we are successful at treating some of the cardiovascular or other parameters, we may or may not see the same impact on their quality of life or benefits if that's not the main problem. And so we came up with this term of POTS and POTS plus. So there's other stuff going on. And similarly for the postural symptoms without tachycardia. And from the CCS document and in the citations here, it's open access. We list some of the associated severe symptoms that could be driving quality of life and some of the associated comorbidities. Ehlers-Danlos syndrome is seen probably in 25 to 30% of POTS patients, and certainly the hypermobile form is by far the most common, I think in general, but certainly in our subset of patients with POTS. A smaller minority, but important, seem to have sometimes get a co-diagnosis of mast cell activation syndrome. And I say that with hesitation because I'm not entirely sure what that is anymore. But what I can tell you is that these patients have a very strong allergic or immunologic tendency where it can be hyperactive. Whether it involves the mast cell specifically, I'm not sure. And overlap with chronic fatigue syndrome. And a significant number have a constellation of different autoimmune diseases that may be driving it. There will not be a test on this. This is a flow diagram that we made actually at the request of reviewers when they were going through our document. And really, this is if we just, I guess the reviewers wanted a simple way to take the different terms in the ecosystem that we came up with and be able to have a patient in clinic and figure out where they fit into the overall scheme. And so this is for that purpose. Again, this is one of those things that you could actually pull up on your phone or keep in a pocket card if you had patients and you weren't sure how to deal with them, but not something that would be tested. So the common symptoms of POTS are listed here, and it's broken down, from a cardiologist perspective, right? So I sort of took symptoms that I thought could reasonably be attributed to the heart or cardiovascular system more broadly on the left, and symptoms on the right that's tougher to really blame on the heart, right? So rapid heartbeat palpitation, chest discomfort, dyspnea, lightheadedness, all of this, could certainly be driven by issues related to tachycardia. But a lot of POTS patients, as you're going to see, will complain of, mental clouding or brain fog or subjective cognitive impairment. Over 90% have headaches that are daily and bothersome. A lot are nauseated. And many will describe a tremulousness, right? And whether that's actually related to the heart is harder to pinpoint. The symptoms on top here in black are all symptoms, both on the cardiac and the non-cardiac side, that get worse with upright posture. But there are symptoms shown in blue lower down that aren't necessarily positional. So exercise intolerance is almost unique. Almost universal. Fatigue is universal. And the majority have sleep complaints that obviously are not only with upright posture. Slide shows a representative tilt table test with a healthy control subject on the left and a POTS patient on the right. So this was done when I was at Vanderbilt. Healthy control subject meant grad student at the time. We have a heart rate channel on top, a blood pressure. This is a continuous blood pressure in the middle, and the tilt angle. So just so you can see when the table went up and the table went down. So a couple of things to take from it. The first is, if you look at the healthy control subject, the heart rate goes up during tilt, right? So orthostatic tachycardia is not pathology. That's actually physiology. The second, if you look at the blood pressure and compare the blood pressure in the control subject to the POTS patient, certainly the average blood pressure is not low in the POTS patient, right? If anything, it may be slightly higher than the control subject here, but comparable. Now, the careful observer would look at the trace and say, the POTS patient trace looks different. It looks a lot spikier. It's sort of like I can sometimes look when in desperate need of a haircut, where you just can't get all the little squiggles to sit down. And that actually may be really important, something we're actually interested in from a research point of view. These blood pressure fluctuations may be a sign of the cardiovascular instability, and we may be able to quantify that. And finally, if you look at the heart rate in the POTS patient, again, like the control subject, it goes up, but it goes up a lot, much more aggressively than the control subject, early and sustained, and it keeps going up. And in fact, in this particular patient, we put the tilt down before the end of the protocol because she asked us to. And at the time, her heart rate was almost 180 beats a minute. And as I mentioned, symptoms are critical. And so we were rating symptoms every few minutes. And you can see that the control subjects in black, for the most part, were asymptomatic. Every once in a while, they'd get a little bit symptomatic, and then they'd faint. They'd actually have vasovagal syncope, and they'd sort of drop out of analysis. In contrast, the POTS patients were symptomatic early, and it continued throughout the tilt. The POTS patients would tell me they're about to faint, and they kept telling me that for 30 minutes in this tilt protocol. And the key lesson from this, is that, well, the interesting thing, and I one day I should put this on the slide, is that a higher proportion of the POTS patients survived, made it through the 30-minute tilt than the healthy control subjects. The healthy control subjects had a higher rate of vasovagal syncope than the POTS patients. And the lesson from that is that POTS is not fundamentally a fainting disorder. POTS is a disorder about feeling faint, not necessarily fainting. So what does it look like? So, we had done many studies, single center studies, first at Vanderbilt and then, in Calgary, and Mayo did similar things. But most of the work was limited to, 15, 20, 25 patients, what you could muster from a fairly large single center site. But did that represent the broader community? And so we partnered with Dysautonomia International, which is the largest POTS patient advocacy group And this was, and we ran a study basically through Vanderbilt University Ethics. We now have data sharing agreements with the University of Calgary, so we're working on it here as well. And basically, we administered a large cross-sectional patient community survey. And this was largely distributed through the dysautonomia channels to give us a sense of what the patients looked like and what some of the big issues in were in their lives. So in terms of demographics, it actually looked a lot like our littler studies. So the vast majority, over 90% of the respondents are female or were female. Over 90% were white. And again, the reasons for this aren't clear. In theory, web-based, social media-driven stuff is more democratic than, having to come to Vanderbilt or to Mayo. But still, the survey was only in English, and that may have skewed this somewhat. And then if you look at the age of onset, two things come out of this. First is there's, the most common age, the mode was 14, right? So huge incidence right around puberty, predominantly in females. But there is sort of a long tail, and if you sort of break this down by the age of 18, under 18, over 18, it was just a little under half actually developed this late. And this may reflect the heterogeneity of what causes POTS and reflect different mechanisms at play. We had a laundry list of symptoms that we asked patients to endorse or not. And the most common ones are listed here. And the first few, I think, are ones you'd expect: lightheadedness, tachycardia, presyncope. But then, almost as common, headache, difficulty concentrating, nausea, memory problems. So again, what this is trying to show is that POTS isn't just a cardiovascular issue. It's actually a systemic illness with a prominent cardiovascular manifestation. And from this survey, we list some of the commonly listed comorbidities: migraine headaches, quite common; irritable bowel syndrome, Ehlers-Danlos syndrome, as I mentioned, 25 to 30% overall. A significant minority have gastroparesis. They often do well. Vasovagal syncope, present, but not in the majority, right? So it's absolutely true that some POTS patients faint, and almost always it's due to vasovagal syncope as the mechanism, but it's not the majority. And then, less common are a handful of different autoimmune diseases. And this is one of those things that we've seen consistently, where if you clump them together, it's actually not an insignificant number, but it's not one autoimmune disorder that seems to be linked to POTS. A lot of these patients, develop their POTS as adolescents, as teens, and one of the important things in the lives of teenagers is school. Obviously, this is a time in their life when they're setting the trajectory for the rest of their life. And to that end, POTS is a major problem. Almost 90% of patients missed school due to their POTS. 30% were homeschooled, again, largely due to their POTS. 25% had to drop out of school at some point, and almost 40% had either delayed university or had to gap out, postpone enrollment. Their education was affected. So this speaks to the importance of trying to get on it relatively quickly, especially in this younger group. So what about quality of life? And some of this work was done with Kanika Bagai, who's a sleep neurologist at Vanderbilt. And the study focused on sleep. I'm going to talk about the quality of life impacts. And just to say that the data I'm showing here is not ours. We looked at the SF-36, and I know many of you are familiar with the SF-36. It's a ubiquitous health-related quality of life tool, not specific for any disease or disorder, which is both its greatest strength and weakness, right? So you're not going to pick up more subtle or nuanced findings, but it's been studied in just about everything. And so it's good for comparison across disease states. And we have two disorders here, disorders that are generally associated with a fairly poor quality of life. So patients with chronic back pain in green, and patients with end-stage renal disease on hemodialysis in purple. And our POTS data is just superimposed on this slide in red, right? So this doesn't speak to why patients have a poor quality of life, but the POTS patient's self-described quality of life is comparable to published data of patients on hemodialysis. So one of the challenges is that there are people, including sort of autonomic experts, who basically think POTS patients are crazy, right? And so this was actually assessed, and this work was done by my wife when at Vanderbilt. She was a research fellow in psychiatry before actually doing her psych residency, and they had NIH funding to look at this. So this was patients we brought into our research unit, and they did a very formal structured assessments. Right? So this is really the question they're asking: are POTS patients crazy? And so the short version is maybe, but no more so than the general population. So they mapped, they did a structured long interview and mapped to DSM-4TR to look for hormonal diagnosis. And some people had depression, some had anxiety, but at rates seen in the US general population. But they found some interesting thing on sort of psychometric assessment. So anxiety is one of the things that people talk about a lot. But when looking at anxiety in the POTS patients in red compared to the normals, the rate was higher. But you have to be careful when reading studies like this, because my wife pointed out quite happily, actually, that I would not have qualified as normal, right? So these were patients that were screened to be psychiatrically uber normal, and I didn't make the cut, right? So perhaps because of that, that's not the best comparison. The better comparison might be the general population, right? There's a certain amount of anxiety and depression and other stuff in the general population. And the question is it worse in this group? And the answer is no. And this is US population data. I don't know that we have reason to believe the Canadian data are different. But the POTS patients actually are a little bit anxious, but no more so than the general population. What did come out that was of interest was about attention or inattention. And so using this is a Conners Adult ADHD Rating Scale, CARS, the POTS patients actually had more inattention problems than both the normal population as well as the general population, the background population, but not as much as patients diagnosed with ADHD. And this was relevant because we'd been hearing from POTS patients they had trouble with memory, but this is the first thing that got us thinking that maybe the problem wasn't just memory, maybe it had to do with attention and information processing. And it led to a more detailed neurocognitive study that we did when we were at Vanderbilt, looking at different tests of different processing functions, I guess, looking at both attention and looking at executive function. And there were abnormalities. Now, this wasn't across the board. There are different types of memory that weren't affected and some that were. In other studies that have looked at this, executive function is the one thing that consistently pops up as abnormal. Now, the challenge with this is at a group level, we see problems, but there is sort of a fair bit of spread in the data. And at an individual level, it's tough, especially because we almost never have pre-morbid testing. We never have neurocognitive testing before the patients got sick to judge what the impact was of their POTS. And so if you have someone who's functioning at a fairly high level that drops significantly, they may still be in the normal range. And the testing would just come back as normal, even though they feel like they're not working, their brain's not working as well as it used to. One of the, I don't know if concerns, one thing that people would argue is that, this is all psychological and the heart rate response is really driven by that. And to that end, there was a beautiful study done several years ago now by Mike Joyner's group at Mayo. And what they did is they put patients, POTS patients in black on top and healthy control subjects in thinner black on the bottom into a lower body negative pressure chamber. So the old versions of this that I used when I was a fellow here looked like a coffin or an iron lung. And you put the patient in it from the waist down, and you hook it up to a medical suction device. I mean, we used an old Electrolux vacuum cleaner, and you suck blood. You suck air out, and so blood shifts from the chest, thorax, to below, right, into the legs. And so you simulate standing in that way while horizontal. And what they showed, you see on the left here, is that the POTS patients had a slightly higher heart rate to begin with. And as you sucked more blood, you can see the lower body negative pressure increasing. The heart rate in both the POTS patients and the healthy controls went up, but it went up much more so in the POTS patients, while the blood pressure shown on the bottom, the MAP, was basically unchanged. Now, what they had done is actually they did this study with patients wearing mask pants, which are basically, air inflation pants that I think its main use in life was in ambulances for patients with long bone injuries in the leg, where you could actually splint the legs. So they did the same study, this time with the masked pants inflated. So you had basically an airlock around the legs. And so when you applied the suction, it made the same noise. It made the same, the room was still sort of disrupted, but the pressure, the negative pressure in the box was not being transmitted to the legs because you had this airlock from the mask pants. And when you did that, the heart rate was still higher in the POTS patients, a little bit to begin with, but really there was no change, no matter how much noise and other stuff was going on, right? Suggesting that, if it was anxiety in the general environment, you'd expect the heart rate to go up. But this would suggest that the heart rate increase was actually a response to hemodynamics, the fluid shifting to the legs, and consequently the decreased cardiac venous return back to the heart. So I'm going to shift gears and just hopefully finish with a what to do about these patients when you do see them. The investigations really are fairly basic. There are at least a couple of position statements that have opined on this, the Canadian Cardiovascular one, and before that, a few years before, the Heart Rhythm Society came out with one. But most of the benefit actually comes from a detailed history and more history and more history, and then some physical exam, right? These patients have often undergone a long journey. There are a myriad of symptoms, and they may have trouble figuring out what's related and what's not. And it takes time to really sort through that. And that's a challenge in our healthcare system. A focused physical exam is useful. The critical bit is orthostatic vital signs. And the heart rate increases that we talked about in the beginning, I probably should have specified. You have 10 minutes. The patient has 10 minutes to reach that. So you need, supine and then a 10-minute stand with at least intermittent measurements of heart rate and blood pressure. And some basic blood work is recommended to rule out obvious other causes, rule out severe electrolyte disturbances, rule out severe anemia. You don't want to, hyperthyroidism is treatable, and you don't want to diagnose with POTS if that's the problem. A fasting cortisol at some point is probably reasonable, just to make sure that there is some. It's not a subtle finding. It's if the cortisol is absent, that's a problem. Otherwise, probably not the cause. And then there are other tests listed here that we don't necessarily do routinely for everyone, but may be worth doing. Certainly a lot of the patients I see that are not responding will sometimes do autonomic reflex testing or autonomic function testing. That's not widely available. Echocardiography is worth saying something about. And that is to say that one way or the other, if you're seeing these patients, you need to be confident that their heart is structurally normal. And if, these are often young women who are relatively thin and whose cardiac exam is quite feasible. And if you're comfortable based on the history and exam that it's normal, you do not need an echo. However, if you're not sure that the heart is normal, if for whatever reason the exam is inconclusive, then an echocardiogram is probably quite reasonable. I was referred a patient years ago who, the referral was that she developed POTS in pregnancy, which does happen. But the problem was that she actually developed a peripartum cardiomyopathy. And the treatment for the cardiomyopathy and the treatment for the POTS are quite different. So you don't want to miss a cardiomyopathy or something like that. The heart is structurally normal in these patients. The foundation of treatment for POTS is non-pharmacological. That doesn't mean that all patients will respond to this alone, or even that the majority will, but all patients should be offered these treatments, and efforts should be made at every visit to really double down. And these consist of increasing dietary salt and water intake, a goal of trying to increase fluid retention and increase blood volume, the use of lower body compression garments, and exercise. So, for years, people have been recommending, increased dietary salt in POTS patients, but surprisingly, the data for that was really, really poor until recently. And so this is one of those things I realized when I was at Vanderbilt, and we actually got an NIH grant to look at salt regulation. And we did a dietary salt study where we brought patients and some healthy subjects in twice to our clinical research center for 1 week at a time. And on one of them, one of the 2 stays, we gave them very low sodium diets. And on the other, we gave them a very high sodium diet. And we did nothing for several days. We just let them eat. Because it takes a while to reach steady state. So after 6 days of this, we actually did fairly detailed evaluations. We formally measured their blood volume. We did stand tests or posture studies where we looked at the hemodynamics, but also drew blood for norepinephrine levels in the plasma, right? So this is norepinephrine is the main neurotransmitter in the sympathetic nervous system, and it's not a perfect measure of sympathetic nerve activity, but it's an accessible biochemical marker that's pretty useful. And what we found is that salt did exactly what we thought it would do. So if you go from a low salt diet to a high salt diet, we did increase the blood volume. Now, in a week, we increased the plasma volume, the liquid part of blood, and not the red cell volume, which I think is what you'd expect. If we did this longer, it's possible the red cell volume would have also increased to catch up, right? So we effectively dropped the hematocrit a bit because we increased one component and not the other. But with that decreased the sympathetic tone on standing, or decreased the increase in sympathetic tone on standing. It didn't increase as much. And with that decreased the orthostatic tachycardia. So the heart rate didn't actually go down. The heart rate didn't go down as much, or didn't go up as much, sorry. Right? So fundamentally, increasing dietary salt intake worked. So how do you do this? Since this is the approach we use in our clinic, we try and get patients to drink 3 liters of water per day. That's a lot. It's absolutely achievable for most of our patients, right? And one of the important things is that the patients actually have a water bottle. And when I say a water bottle, I don't know how many of you are football fans, but there's a saying in football that if you have 3 quarterbacks, you don't have a quarterback. I use the same approach with the water bottle. I want them to have a dedicated water bottle, and I want them to keep it with them all the time, not a bunch they grab, right? They need to have water with them so they can drink regularly and not just when they're thirsty. And to hold on to the water, we want them to get in more salt. And some different position statements are a little bit different. The numbers, realistically are made up, they're guesses, but some say 8 to 10 grams, some say 10 to 12 grams. So I've settled on roughly 10. And a teaspoon of salt is about 5 grams. And so the target is 2 teaspoons. And to semi-quantify it, I'll ask the patients to put those 2 teaspoons in a Ziploc snack bag or some other container in the morning, and then use that to get into them through the day. Most people will add it to food. Some people hate the food with the salt, and they'll, add it to water and do, either if they're younger, saltwater shots, or people will just drink it with hot water and lemon juice, right? Some of this sounds nauseating to me, but it turns out it doesn't matter if I like it. It's whatever works for the patient. It has to be a sustainable approach. I don't use salt tablets routinely. I know some people go to that right away, but I think it causes more gut grief and nausea after doing it, and sometimes vomiting, than dietary salt. And it's also more expensive. But having said that, if someone hates the taste of salt, this may be, a way of minimizing that taste issue. And if they really don't tolerate it, there are gel-coated tablets. Vitacium is one of the brands that you can get on Amazon that are better tolerated, but it gets expensive, right? Not that each tablet's expensive, but you go through a lot. So I don't tend to recommend that unless other things don't work. What about compression? And a lot of this work, when I say a lot, I think all of it, was led by Kate Bourne, who's a PhD student of mine currently, and will be starting med school hopefully this coming year. She's already admitted. And what we did is we brought patients into the lab and used a lower body compression suit, not one that they could wear at home, but one that allowed us to do segmental compression. And we performed repeated tilt tests with different types of compression. And what Kate showed here is that compared to no compression in blue, where the heart rate went up with tilt and then kept going up over a 10-minute tilt, if you actually compress from the abdomen all the way down, so pantyhose style or tights style, you can get the heart rate goes up initially, but then it plateaus. It doesn't keep going up. And we actually looked at 4 different compression modes in the study. The none and the full we showed in the prior slide, but we looked at an abdominal one, which is sort of a bicycle shorts compression, so abdomen and upper thigh, and the leg one, which is more calf. And you can see in a dose-dependent way, symptoms got better the more we compressed. And interestingly, shown on the right, that symptom correlation, the improvement, related to how much the heart rate went up. So the more the heart rate went up on standing, the more symptomatic they were. And as we were able to reduce that, we were able to reduce both the heart rate and subsequently the symptoms. Right, so we recommend this fairly routinely. In a practical sense, we can prescribe pantyhose style stocking. The lessons are calf stockings are almost useless for this. You really need to compress the belly if you want to compress only one thing, but all the way down it works. Tights work, and I usually recommend triathlon tights as the first line. We can go to medical grade stockings, but they tend to be more uncomfortable and aesthetically less pleasing. And so for younger patients, the commercial garments tend to be better tolerated and better compliances with them. In terms of exercise, this is a tough thing in the POTS patients, right? I mean, a lot of them have exercise intolerance, as I said. A lot of them have post-exertional malaise to start with. But a group in Dallas, colleagues in Dallas, did a study in the late 2000s, published in 2010 here, that was a fairly exhaustive before and after study. They measured just about everything, not quite, but just about, before and after 3 to 6 month exercise program that was largely aerobic reconditioning, a little bit of resistance, but largely aerobic reconditioning, and showed that physiology improved, fitness levels improved, blood volume improved, cardiac remodeling, LV mass increased, sympathetic nerve activity. So the nerve firing, they measured that, and that actually normalized, it decreased. All the stuff I'm interested in, but most patients don't care, right? But it decreased orthostatic tachycardia, which patients sort of care about. And importantly, everyone that completed this protocol, which in fairness is not the same as everyone that started, but everyone that completed the protocol reported an improvement in quality of life, right? So not totally, and it varied how much, but everyone improved somewhat if they were able to do this. So how do you do it, right? This is actually the challenge. Initially, I saw the study and we tried to get patients to do it, and they come back saying it doesn't work for me. So if your patients speak exercise physiology, or they have a trainer and they want the information, I think you can get the calendars they use in the study online. I don't speak exercise physiology, so I don't hand out the calendars because I live in fear the patients will ask me questions about it that I can't answer. So I give them the principles, right? So first of all, this is mainly about aerobic activity. It's not just about doing something. So Pilates, great for you. Core strengthening is good, but that's an and, not an or, right? That's not going to buy you the aerobic activity points. If patients are very thin and there's really sort of very poor muscle bulk, they did suggest resistance training focusing on the thighs to build up a bit of muscle, because the muscle can act as a fluid reservoir. But the main issue here is aerobic reconditioning. They prioritized regularity, so at least 4 times a week. And I'll often ask people to try for a little more, because best laid plans will fall apart, right? Things will get in the way. So if they try for 5 or 6 days a week, they're more likely to meet the 4. And fairly quickly, we try and get them to 30-minute sessions. The most important thing that they did in the Dallas study, and that we recommend, is at least initially no upright exercise. And the reason is because if someone is getting their heart rate up to 130 or 140 beats a minute while standing at the treadmill before you turn it on, they're not going to last very long, right? So I'd rather have 30 minutes non-upright than 3 good minutes doing an elliptical or a treadmill. So in the study, they preferred the use of a rowing machine. And a lot of patients do like that. If that's not tolerated for whatever reason, recumbent cycles can be used. Swimming is also, in theory, good. In practice in Calgary, there's not great access to pools, and so we don't use that as much, but it can be quite good. The key message is at the bottom here, and that is, if you tell people to start doing something like exercise, I think most people expect to start seeing some benefit in 2 to 3 weeks. It can take a lot longer here, right? It can take up to 6 weeks before they start to see benefit, not before total benefit, before they start to see benefit as these patients. And in the interim, with the post-exertional malaise, they may feel worse, right? So it's important to warn them about this and manage their expectations, because if they stick with it, often there's light at the end of the tunnel, but it's a really long tunnel. In terms of sort of drug approaches, there's some we'll touch on.
Sorry, Andy was able to log in.
What's POTS?
So, so I'm not sure if someone's...
Sorry, we have
so in terms of saline, so a lot of patients, and I spent a lot of time on this in a mini prior life, have low blood volume. And not surprisingly, if you restore it with intravenous saline, lots of things get better. And this is an acute study from Juris Jacob done, in the 90s at Vanderbilt, showing that acutely a liter of saline after an hour restored, the orthostatic tachycardia to a normal range, right? So if someone is sort of circling the drains, struggling, getting worse, ends up in a merge, and you're trying to figure out if they need to be admitted or not, I often recommend a liter or 2 saline to see if you can get them acutely better enough. That's obviously not a long-term strategy. conversely, long-term saline, like regular infusions, are not recommended. And the main concern is not the saline. The main concern is the port and access complications. And so they're listed as class 3 recommendations, both by the CCS as well as the Heart Rhythm Society. Another strategy that we looked at when I was at Vanderbilt is using DDAVP, desmopressin, right? So this is a drug that promotes free water retention. It's got to be reasonably safe. We give it to kids that wet their bed at night. And it turns out it does help, right? So acutely in this study, we showed that if you give patients 0.2 milligrams of DDAVP with half a liter of water, it lowered the heart rate and it stayed down for several hours. And that's an approach that we can use as a special event drug. I have colleagues that give it nightly, 0.2 milligrams. But the key thing to remember is that this will promote free water retention, and we're telling patients to drink a lot of free water, so it can cause hyponatremia. So it is important, if you're using this, that you periodically check the electrolytes to make sure that patients don't get hyponatremic. A colleague that used it daily had labs set up almost like a Coumadin clinic, where the labs would be done routinely and a nurse would look at it. And what he told me was that if patients stuck to 0.2 milligrams daily, he never had a problem. But some patients thought, man, this pill is so good, 4 would be even better, right? And so that person did run into problems with hyponatremia. So you just have to warn the patient not to take more. Midodrine is a prodrug of a squisher drug, right? It causes venoconstriction and vasoconstriction, works for about 4 hours at a time. And you can see in the same study from Juris Jacob that midodrine helped, but its effects were more modest, or certainly modest compared to saline, right? But it did lower the orthostatic tachycardia for several hours. But if you have it sort of with high heart rate as a cardiologist, if the heart rate's too high, we want to lower it. I sort of came through cardiology at a time where, I had an attending that said, if it moves, beta block it. And so, but the problem is that a lot of patients would tell us, certainly at Vanderbilt, that I don't tolerate beta blockers. I don't do well with it. And so we brought them into our research unit. We had this acute protocol similar to the DDAVP one, and inevitably propranolol, 20 milligrams, regular acting propranolol would be the winner. Like by winner, the best hemodynamic response and the best symptomatic patient response. Patients would do well with this. But we couldn't figure out initially why patients did so well if they said they didn't tolerate beta blockers. And it was actually our research nurse, Bonnie Black, who said, we tend to use low doses because patients can be sensitive to drugs. And when we used a fuller dose of propranolol for more complete beta blockade, the symptoms started to get worse, right? So the key with using beta blockers, propranolol is my go-to, is low dose. You want to take the edge off the heart rate increase. You don't want to fix the heart rate, because you'll probably make this patient symptomatically worse if you do that. More recently, there's a study that came out a couple of years ago out of UCSD looking at ivabradine, a placebo-controlled trial showing that a subgroup of patients with POTS had heart rate lowering and an improvement in quality of life with ivabradine. I think they used 5 milligrams twice daily. This is a funny channel blocker, so it works on the sinus node like beta blockers without the other side effects. One interesting side effect is it can cause visual disturbances and decrease night vision because while the eye doesn't have funny channels, it has a homologue of that. And so it can cause similar symptoms, but fairly well tolerated, a lot more expensive because it's usually not covered by insurance for our patients. Acetylcholine is the main neurotransmitter at the autonomic ganglia, as well as postganglionically on the parasympathetic side. And so we thought this might be a reasonable strategy to try to decrease the heart rate in POTS, and acutely it worked. It decreased the heart rate and it improved the symptoms. And so it can be used as an adjunct, but the truth is it's not potent. What I will say is one of its main side effects is it increases bowel motility, and patients prone to diarrhea or diarrhea problem, irritable bowel syndrome, I would stay away. But if they're prone to constipation, they may love it for their gut, if not their heart rate benefits. And the final drug I'm going to talk about are norepinephrine transport blockers. We tested atomoxetine, but I think the lesson potentially applies to all SNRI drugs, right? The N in SNRI drugs means it blocks this norepinephrine transporter. And as you can see here, this is the only drug we ever tested that increased the heart rate, right? It's a clearance transporter that effectively increases sympathetic nerve activity, both standing and seated. It decreased orthostatic tachycardia and it worsened symptoms, right? So is that to say that everyone would be worse? No, about 2/3 got worse and 1/3 didn't. But I'd be cautious using these drugs in this patient population. And the final thing I'll say, and this is very new data that's come out just in November in JACC EP, but a group in Oklahoma looked at tragus, vagal nerve stimulation using tragus stimulation daily for a couple of months and showed that this decreased the heart rate in some of the POTS patients and actually had a sustained effect in decreasing the orthostatic tachycardia as well. So resting heart rate, the orthostatic tachycardia over time without a big effect on blood pressure. And I believe they showed that one of its mechanisms, and this is still being looked at, but maybe through an anti-inflammatory mechanism, I think it decreased the levels of TNF alpha in these patients. So an emerging treatment, I don't think vagal nerve stimulators are actually approved for this at this point, but this may be coming. So with that, I'll conclude, and just the take-home messages are that POTS is a chronic disorder associated with significant disability. It is a syndrome. It's not one disease, and so there are multiple pathophysiologies that can play into it, and that still needs to be sorted out. The principles of treatment involve exercise, primarily aerobic, focus on volume expansion, both non-pharmacologically and sometimes with drugs, heart rate control. And the final thing, and I haven't actually spoken about this at length, but worth a brief mention, is that all of these patients are going to have this indefinitely, right? They are going to have to live with a chronic illness. And while I'm a human physiologist at heart, the longer I've been doing this, what I've realized is people with similarly objective levels of dysfunction or tachycardia can function at very different levels. And part of it is how they've learned to cope with their chronic illness and live with it and not be controlled by it. So with that, I'm happy to take questions. Thank you.
Thank you so much, Satish, for that excellent presentation. And I just encourage everybody to put your questions into the chat so we can ask them of Satish. It's nice to have an expert with us on this topic today. I think it's something that many of us encounter regularly in practice. While we're waiting for some questions to come into the chat, I'll just encourage everybody to evaluate our grand round session today. We really appreciate that. Quiet group today.
Either it was so clear or so confusing.
Question from Jana. Can you discuss POTS in the context of COVID? And are you seeing more of it?
Yeah, I mean, I think COVID has done a couple of things, right? So there's certainly been a lot more attention towards POTS brought on by COVID because a certain percentage of the patients have developed sort of various autonomic issues, including POTS. And so we actually got one of the one-year COVID grants to look at the prevalence of objective autonomic findings, test findings in the patients with ongoing symptoms or long COVID afterwards. And in our data set, it was about 30% met criteria for excessive orthostatic tachycardia, and all these patients were quite symptomatic. So it has increased the numbers for sure. As to why is a more interesting question. And one of the things that we and other groups are still teasing out is, are the long COVID POTS the same or different physiologically than the non-COVID or the pre-COVID or just the POTS group before we knew what COVID was? Our sense is they're not. A group at Vanderbilt thinks they may behave a little differently. And that may play into whether the problem with COVID is you just had a lot of virus and we already knew that there were viral triggers for some patients, or whether there's something specific about the SARS, antigen or spike protein and its targets.
Thanks for that. And then a question from Andrew Lowen. Thank you. Related to diagnosis, is it straightforward based on symptoms and postural vital signs, or do you recommend referral to confirm diagnosis? And maybe I'll just add to that, like, should these patients be seen by general internal medicine, cardiology? Who should see them?
So great question. So different people in different parts of the world have different thoughts on this, right? So when we came up with the CCS position statement, what became quite clear to us, on the writing committee, is there were very few of us. And if we were to say, you need to see a specialized autonomic center to get a diagnosis, what we're really saying is most of you will never get a diagnosis and treatment. And so we tried to set it up and be clear to empower general practitioners to make the diagnosis in the context of the clinical context of the symptoms and the hemodynamics. Your diagnosis is right there, and you can start treatment. And we sort of outline how to do that. And then if the patient's not getting better and it's refractory, then they can be referred to someone who's, a POTS expert or an autonomic center. As for the who, it's whoever's willing to do it. Honestly, it's, if anyone takes an interest, they can learn. This isn't sort of something that is a rarefied air. And so sometimes, if you go to the autonomic meeting, it's a hodgepodge of neurologists, internists, cardiologists, some endocrinologists, pediatricians, obviously. It really can be multidisciplinary, and there's value in actually having a true multidisciplinary clinic. So if there are others interested in joining us in our autonomic clinic, we'd love to have you.
Thanks, Satish. And next question from Sidra Javid. Thanks, that was amazing. Would you recommend mineralocorticoid for volume expansion in the absence of adrenal insufficiency?
Yeah, so the question presumably has to do with fluticcortisone or Florinef, and should we use that? What I'll say is that it absolutely can be used. Generally speaking, in a study of CFS and in a large syncope study, doses of 0.2 milligrams a day are pretty safe. It doesn't seem to, at least over a few years, it doesn't seem to cause severe hypokalemia, although I'd still check, and wasn't associated with a high rate of side effects. Having said that, I used to use a lot more than I do. And the difference, what's happened over time is I've gotten more prescriptive about how patients should get in sodium. As I outlined, I'm very much, everyone I see has been told to take more salt, and often after they see me, I think they do a better job of it, or at least they come back and their hemodynamics are a bit better. And with that, I haven't found the need to use the fluticcortisone as much, right? Remember, fluticcortisone is part of the salt water strategy. It's just a way of getting the kidney to hold on to more of the salt you take in. But if you just take in a lot, that seems to do the trick.
Thanks for that. As you talk about this, I think a lot about my patient advice I give to individuals who have kidney stone disease and helping people with those strategies to consistently increase up their fluid intake. And there's a lot of research on developing habits. And I think that's kind of what we're trying to help people do in our practices when we're helping people live with chronic conditions.
Absolutely.
And then a question from Andre: do patients who do not meet full criteria for POTS respond to the same treatment?
So, that depends. It really does. And it probably depends on what the underlying cause is. So in the postural symptoms without tachycardia, you could simplistically say, well, there's some people who have orthostatic symptoms. When you do the orthostatic vitals, the heart rate goes up by 10 beats a minute, right? In a patient like that, I'm not sure that some of the strategies, certainly lowering the heart rate, is going to be helpful. Conversely, there are patients that whose heart rate went up 27 beats a minute and didn't quite meet criteria. And there is some diurnal variation where if they were assessed in the afternoon, that's going to be a little lower than in the morning. In those situations, I think the heart rate is probably more than expected, even though they don't meet criteria. And I probably would start with similar strategies. Unless the heart rate's really, really fast, it may be better to try the non-direct heart rate approaches, right? So the avapritinol and the propranolol, for those who get prodigious heart rate increases, I find it tends to work better. If the heart rate is sort of more marginal, then certainly the volume strategy is still helpful, and maybe the mitidrin may be more helpful. The non-pharm is for everyone.
We can all exercise more. Thanks. So Jane has a question for clarity. Can you develop POTS at any age, or does it largely occur in the teen years, early adulthood?
Both. Right. So, I think, our data shows that there's, a huge constellation that develops it, when they're, teenagers, young adults. The truth is our pediatric colleagues probably see more of this than I do. Our clinic starts at age 18, but you can develop it later. One of the challenges, though, is that, as I mentioned, orthostatic tachycardia, the physiologic normal orthostatic tachycardia decreases. And so you're sort of fighting a bigger uphill battle, I guess, as you get older, and that may mask it a little bit. As a general rule, though, when I get referrals for POTS in someone in their 60s and 70s, it almost always is orthostatic hypotension. right? As we've gone from POTS not being recognized to POTS being on the tongue, but with those symptoms, almost always when you look at the pressure, they have orthostatic hypotension driving their issues, not the POTS. But it can occur certainly in the 40s, 50s, and sometimes even in the 60s.
So thanks so much for the wonderful presentation, Satish. I've got lots to think about, and I thank you so much for doing this combined cardiology and medicine grand rounds. And I'm just going to get Pip to switch over to the next slide. So Connect Care tip for this week is to use the appointment desk to see what's happening with your patient. So I just picked a patient here who has a lot going on. So if you want to see admissions, I showed active requests here. So if you want to know when somebody's going to see a patient in follow-up and they haven't been booked yet, you can look in the active requests. And then I showed here on the slide how to get to the appointment desk and favorite it. Next slide, please. The Connect Care session this week will be a Dragon Medical One optimization. We have Dragon educators coming, and you can do some of the group stuff, and they'll teach you how to do one-step commands, auto text, managing your vocabulary, and give you information on how to set up one-on-ones. Next week is Steve Thompson from Rheumatology doing Say Cheese media in Connect Care. Next slide, please. And this week's unsung hero is Sonia Sarkozy. She's a hematologist at the Peter Lougheed Hospital. And I just wanted to give Sonia a big shout out for her work at the Peter Lougheed and also on Specialist Link. And just a big shout out to the hematologist who actually answer 20% of all the Specialist Link calls that come into the Department of Medicine. And they're a smallish division, and they are fielding about a fifth of our Specialist Link calls. And so all those questions about the abnormalities of the CBC, and they save a lot of referrals, and I really appreciate their efforts in that. So thanks, everybody. So if you have a topic for a Connect Care session that you would like us to do, or an unsung hero, please do reach out to me. Just send me an email, and we will make it happen. So thanks to everybody. And again, please evaluate the session, and we'll see you on the screen next week.
Thanks again.